las riendas.
Podemos sentirnos
Un equilibrio entre la mujer y el hombre, ¿no?
All right, well, today we have Shereen Lim on the podcast at 360, and I could not be more excited for the questions, the interview that we are going to record, all about airway, breathing, thriving from childhood to adulthood. Thank you, Shereen, for coming on to my podcast all the way from Australia.
Yeah, no, thanks very much for having me, and it's great to connect. And thank you for having me as the first English episode.
Yes, I love it. All right, Shereen, tell us a little bit about yourself.
Yeah,
Who are you? How did you start into thriving and breathing?
Excellent. So, yeah, I'm a general dentist. I have been a general dentist for 26 years now, and I first became involved in breathing through my husband's snoring. So because of my husband's snoring, it was driving me crazy. I learned about mandibular advancement devices, how these gentle devices could help support the airway during sleep and help people breathe better. And I decided I was going to learn more about these to help other spouses in the same frustrating situation. So that's how I became involved with it. I got a graduate diploma in the area, so I became one of Australia's first dentists to qualify to be able to treat adults with snoring and obstructive sleep apnea. But then once I started receiving these referrals, I was wondering how come if this problem can actually impact or affect people's quality of life negatively, why are we not addressing this problem earlier? There's a jaw structure problem when we're providing these dental appliances. How come we don't grow the jaws properly in the first place? And so that's why I became involved with early interceptive orthodontics and myofunctional therapy and addressing the poor muscle habits that contribute to poor jaw development. That includes promotion of breastfeeding, looking at tongue ties, and getting the muscles working in the earliest years of life.
Of course. So do you think now you've changed from adults to children, or you're still doing both?
Yeah, definitely. I'm much more involved with children now because I think mandibular advancement devices, it's really a Band-Aid solution. It's really only for nighttime and it's not particularly precise either. I think a lot of the time the issue begins when mouth breathing starts and we need to promote nasal breathing early as possible. And oftentimes what we overlook is the structural contribution of the palate because when our top jaw is narrowed, it is a narrow nasal passage, and that's a missing link in obstructive sleep management, apnea management in adulthood, but we can actually intervene a lot earlier during childhood with much more simpler process. So that's why I have become involved in it, because it's not always easy for us to find a provider that will do adult expansion. It's a lot, you need a lot more progression, and it's newer. Whereas for children, it's a little bit easier to manage.
It's easier and less invasive, I imagine, right? To treat a child instead of an adult. I mean, the expansion.
Yeah. And really, those earliest years of life are the most critical to have good restorative sleep when the brain is developing so rapidly. And if we can treat earlier, we can actually save children from a lot of problems and help build the foundation for them to thrive with their learning and, their health for life.
Yes, of course. What could you tell us about the sleep patterns in children? Because I know that sleep is not always very rhythmic in children. They go by peaks. And there's this thing called obstructive sleep apnea in children, which is it manifests very different in children than in adults. There's also airway resistance syndrome classified in adults. Is that the same thing in children? What are the stages that we go for, or what do you see in children and their sleep?
Yeah, generally speaking, obstructive sleep apnea tends to be an adult problem. If we see it in infants, it's usually related to craniofacial, poor craniofacial development or structural problems, or muscular problems, including tongue tie. So really, when it comes to obstructive sleep apnea, it is largely adults. it's usually because the sympathetic nervous system is not working as well. Whenever there's a limitation of airflow, there is a collapse of the airway. Obstructive sleep apnea is largely an adult problem. It's largely an end-stage problem where we have prolonged pauses or collapses of the airway, which interfere with oxygenation. And in infants, it's very rare unless there's a significant craniofacial abnormality or underdevelopment of the jaws, or there is a muscle hypertonia. So with premature babies or tongue tie, that kind of risk factor. So usually with adults, it is occurring because the sympathetic nervous system is less responsive to any interruptions in airflow. So that's why we get that prolonged obstruction. However, when we have children or the premenopausal women or thinner individuals where the nervous system is more responsive, anytime there is an airflow limitation, there's an arousal from sleep, sometimes accompanied by some grinding to keep the airway open, and it's very protective against sleep apnea. So we won't get those prolonged obstructions, but it doesn't allow people to enter into deep sleep. So that can be called upper airway resistance syndrome, where there's increased resistance to airflow, but the body is compensating and creating chronic stress. But even before those issues, we have to not overlook snoring or even mouth breathing in children, because we know that they will lead to unrestorative sleep. And there's also evidence to support that with mouth breathing alone, children will tend to have increased risk of ADHD type symptoms.
Yes, and that's where I wanted to go with the ADHD.
Yeah.
But first I wanted to ask, now that you've said mouth breathing, I've recently started looking a lot, and because I've gotten involved, I ask patients a lot and I see the babies. There is this mouth breathing with the tongue posture in a correct place. Is that correct? Or the lips have to be sealed? By mouth breathing, what do you really depict? Is it just the lips open with the tongue positioned low, or is it?
I think we
What
want to
is it?
have closed lips with the tongue lightly suctioned to the roof of the mouth. So once the tongue is up, it's impossible to mouth breathe. But if we can have the closed lip seal as well, that is our best tone for the airway.
Okay. And how come nasal breathing is, how do you call it, associated with the parasympathetic nervous system being activated and a lower cortisol and a better oxygenation? What is it that it's in the nose that or in the hard palate that ensures nasal breathing and helps the body?
What is unique about nasal breathing? Really, the nose is specially designed to take in air. So it is designed to warm, filter, and humidify the air. When we breathe through our nose, we can actually get the nitric oxide that is produced in the paranasal sinuses. It is introduced into our airflow, which is antimicrobial, as well as a good vasodilator. So it promotes good oxygen exchange. And also when we can have that deep breathing, yes, it will actually be better for our nervous system. When we can use our diaphragm, in particular with our nasal breathing, we know that that puts us into a parasympathetic or rest and digest state, or more relaxed state.
Ah, right. Oh, so you, sorry, I'm just joining links here. You think that it's the tongue being resting on the hard palate, nasal breathing, that act, and the connection with the diaphragm that essentially sets this like parasympathetic moment. I thought it was because I've been digging, and I think I remember from reading your book that there is a receptor for the parasympathetic nervous system on the roof of the mouth, not on the roof of the mouth, on the hard palate. There's a nerve endings that activate the vagus nerve. Is that right?
Not the vagus nerve, but on the end spot where we put our tongue tip to the end spot, just behind the upper incisors. That is an area rich in sensory receptors, but it is actually a branch of the trigeminal nerve rather than the vagus nerve. And so when the tongue stimulates that area, yes, it's involved with neurotransmission. So it's involved in sending signals to the brain to stimulate the release of neurotransmitters, including dopamine and serotonin, which tend to be more calming and relaxing.
Right, that's where I wanted to get to. I've been trying to explain this to myself or trying to make a picture of it. I've researched and you've said it so well. Thank you.
Yes, that is actually work by Antonio Ferrante, who is an Italian dentist. And he's done 4 textbooks on myofunctional therapy. So a lot of the work is in Italian. He did 1 lecture in English, and I bought the recording and I listened to it about 4 times. I don't think it's easy to find that information.
Okay, you told me already. Alberto Ferrante. All right. So is that why you think children that are doing breastfeeding, dummies, or thumb sucking, is that why you think children do that? Is that to activate this area to give that serotonin and the dopamine and that comfort?
Tongue is up there, everything can work normally, and we will have that normal neurotransmission, and we will have our optimal breathing when our tongue is up, because we cannot breathe through our nose, and it keeps our airway open.
Right.
But when we see things like overuse of pacifiers, or when I see children that suck their thumb, or they love to put stuff inside their mouth, I think they're missing that normal sensory input that comes from having the tongue tip postured correctly.
That's where I wanted to get to.
And so that's usually when I see a child that has all the habits and likes to put things inside their mouth, I usually assume that their tongue is not sitting in the correct position.
Right. Okay.
And, I think a lot of people, or not a lot of people, but oftentimes when we teach people to put their tongue in the right position, there's a sense of calm that comes with it. And even, for instance, children that have thumb sucking and they struggle to give up the thumb sucking, what happens is when they're on board, when they actually want to give it up or they're motivated and they do myofunctional therapy and they're taught where they can place their tongue tip, in addition to a few different barriers like varnish and nail polish and gloves, they're actually able to more successfully stop the habit because they have a replacement habit of putting the tongue tip up that is actually addressing the underlying cause. And Antonio Ferrante, he has actually done research to support that there is a neurotransmission basis for thumb sucking.
Right.
That is what that thumb could be doing to stimulate that palatal receptors.
Okay, that's where I wanted to get to, because I find it very interesting how children, without really knowing what it is, they just do it and they get addicted to it. I have suffered of thumb sucking. And it was immediately after I gave up my dummy. So I really don't understand, and it took me ages to get rid of. And I see patients, and I actually saw recently a patient who, when she was encouraged to get rid of the thumb sucking, she was actually sucking these 2 fingers. It was strange, but it's a thing. And I informed her and her mom of what the situation was and all the problems that she was having at sleep. I gave them your book, and she stopped, and they loved it. It changed her whole life, and I find that just magic. Well, not magic, it's not science, but I find it great how when you get someone motivated into changing, you actually reap the rewards of the effort that you're putting into changing and your body working as a whole. that's the whole reason why I started this podcast. I think it's very useful for people to know, because if they don't know, they won't change. What do you think? This is off topic, but I would love to know your opinion.
Yeah, I think we underestimate the tongue. What is the tongue supposed to be doing? Where is the tongue supposed to be lifting? It's the tongue elevation. Uh, and the tongue tip is the first place that we need to get correct. Up, N, because that's where we can develop our speech perception, our speech articulation, proper swallowing, proper palate development, proper breathing, and
Wow.
fulfilling that sensory input that is required.
Where do you say the tongue has to be positioned? The tongue tip, behind your incisors, or just
Yes.
on the arch? No, behind your incisors. Okay.
Basically, wherever we say N, and it shouldn't touch
And
the tongue.
oh,
So
okay.
it shouldn't touch the
And
teeth. And if we use our tongue tip and press really hard on that spot and we swallow, we shouldn't see any of the face move.
did you see it?
Did you try it?
Yes.
Sometimes it's hard because if the tongue doesn't have enough strength, it will come off and then,
Yes. And I
then
see
we will
that
see
as
the face
well.
move. Yeah.
I see that as well. I ask people to do the sort of lifting and sucking
Yes.
the tongue onto
Yeah.
the hard palate, and
Yeah.
people don't know how to do it. It takes work.
Takes
Also,
practice.
doing it on demand, sometimes it's a bit hard, but anyway. Well, that's very interesting.
Yes.
I practice. Whenever I can't fall asleep, I press very hard, and it just automatically puts me to sleep. It's crazy. The power of the tongue. But let's get back to children. What do you see the main concerns of these children that have poor tongue mobility being, other than breathing? I know breathing is like the mother of all the symptoms, of all the pathologies, but what do you see? You've mentioned ADHD.
Yes, when we see children that have restricted tongue mobility, it can affect breastfeeding. So obviously the most efficient way to transfer milk from the breast is with tongue suction. So as the tongue rises, it actually pushes the malleable breast tissue, and that can actually promote the good palate development. And then the tongue drops and it produces the suction, which is how we transfer milk most efficiently. So when we are not able to get that efficient tongue suction, it's still possible to breastfeed, but often there'll be clues such as painful latch or distortion of the nipples or a lot of nipple trauma, or it will be perceived as low supply because the baby's not able to transfer milk effectively, and so they may tire very easily at the breast or come on and off and have low weight gain, or they could actually have poor swallowing. So if we don't get our tongue lifting correctly, we can actually take in more air. And so that can lead to reflux-like symptoms where babies are arching or very uncomfortable feeding, and they need to be held upright and difficult to settle because they're taking in a lot of air and they're quite gassy. And that can even apply to bottle-fed babies as well. And so when these swallowing issues aren't addressed, as children get older, these are the kids that have more sensitive gag reflexes, or they may have trouble with manipulating their food, or swallowing it properly. They don't chew their food properly, may have more digestive concerns. And then we have the speech delays or the speech articulation issues, where we have children that are going to have speech therapy for multiple years without making progress, but no one's really having a look at the tongue mobility. And the sleep problems, as we discussed, a lot of the time, if we don't address restricted tongue mobility, we can use other muscles. But
Yes.
what happens during nighttime is when everything is relaxed, everything's floppy, we're more prone to lying on our backs. If that tongue is not elevating correctly, it will not work in its function as an upper airway dilator. So it keeps the throat open during sleep, and we'll have more breathing disturbances. or symptoms like teeth grinding or unrefreshed and unrestorative sleep, which then create more problems as well with the behavioral concerns and, mouth breathing and teeth grinding with children. But yeah, I see a lot of issues. Even the swallowing problems, they can be seen in children with reflux symptoms as well. So a lot of children, if they're not breathing really well because their tongue's not working well, they may be more prone to reflux-like symptoms, or air reflux, where they are during sleep. And that can actually lead to collapse of the airway. And those vacuum pressures can actually allow stomach contents to aerosolize into the throat, create symptoms like chronic cough, enlargement of the adenoids and tonsils, postnasal drip, bad breath in the morning, increased risk of decay, increased risk of teeth grinding related wear, even erosion wear. So there's a lot of issues. And when it comes to adults, yes, we'll see a lot of the mouth breathing, the snoring, the obstructive sleep apnea type of symptoms. But then adults will tend to have more compensation and other chronic pains that occur because they're overusing their other muscles, including their neck, and that can lead to referred pains and chronic tension as well. Just because there's like chronic fascial restriction and tension in the body, which can actually be connected to the rest of the body through the fascia. Yeah.
You've mentioned so many symptoms, and it's just crazy. And I don't think parents are aware of the foundation of all these problems. It's true that I had seen a relationship with a dental decay, dental wear, grinding, and poor sleep. But or poor, I don't see it so much as poor sleep. Maybe I see it more like a nervous child. When you start seeing that the child is very agitated, you see that maybe at home it's not the best situation, and that's when I thought it was something to do with the nervous system. When you're very activated, nothing's sort of regulating well on its own, and the saliva is not as defensive. But it's crazy how you dig a little deeper and you keep finding more things. Is it something that you see on every child? There's like a tick box, because I often find myself asking questions to my patients, and it's like they don't sleep bad. They 1 or 2 nights a week, maybe they have bad sleep, and then maybe they have constipation 2 or 3. It's not like always very synced. I don't know. What can you tell us about that?
Yeah, I think there's a lot of behaviors that are really considered normal childhood issues, whether it be teeth grinding, bedwetting. Parents think that they're things that children will grow out of, or terrible twos, tantrums. But really, we're not trained as parents to really understand what normal should look like. So with the breathing, we want to make sure. A lot of parents are quite happy if their child goes to sleep and doesn't wake them up. They don't want to know what their child is doing. It's just a good night's sleep. But really, we need to make sure that children are silent. They're not making any sounds. They have their lips sealed. They're not tossing and turning and sweating and looking like there's a lot of effort involved. If there's any teeth grinding or stomach sleeping or sweating, all those grinding, all those issues could alert us that there is an issue that we shouldn't overlook. But yes, we're just really not trained to look at all these things. And like you said, you have brought it to the nervous system a couple of times, where if a child is not breathing well or they're having interrupted breathing during sleep, it's a chronic stressor night after night. And so sometimes this will manifest as issues like anxiety or separation anxiety, even just children being a bit on edge. And I see that a lot when we can get a child breathing better. It's easier for them to manage, and even the separation anxiety with drop-offs during school, that can go down quite a lot. Or the insomnia, where children are fighting sleep. They don't want to go to sleep. They're just wired because on a unconscious level, they may actually not associate sleep with being a very peaceful time of the day. And yes, a lot of the constipation, a lot of those issues is really from chronic stress. If we are not getting that parasympathetic state, then a lot of those rest and digest functions don't really work well. And so I have also seen that when children can get a better night's sleep, some of those digestive concerns, they can actually be alleviated.
Yes. So what is your question to parents straight away when you see a child? Does he sleep? Or do you just, because I feel like a lot of children, especially nowadays with iPads, phones, and the TV culture that there is, don't get good night's sleep. But not necessarily everyone has a structural problem, do they? It's just another problem. So I find that sometimes parents or even kids feel a bit like taken aback if you ask them straight away, "Oh, are you sleeping properly?" Maybe is the conversation. I don't know. How do you manage it at your practice?
Yeah, well, we have a questionnaire, a form that parents can fill out before they come, and realistically, it's really just a prompt to get them to think about these things. But then when they come in, I usually don't really want to say, "How is your child sleeping?" I want to ask them questions. I'll go through a bit of a routine. Does your child have any troubles getting to sleep? Do they make any noise, mouth breathing? So we'll kind of ask them all the questions to see if that can prompt any red flags that we need to be looking at. Because like I said, if we don't really ask those questions, parents will not check, or they'll think their child sleeps really well.
Most of your patients are babies, or what ages are your patients? Because I feel like you accompany the pregnancy, don't you? If you're going to be seeing the baby newborn, you're going to be managing the whole pregnancy, or do you not get involved in the pregnancy?
No, I usually will only see an infant after they've already seen a lactation consultant. So
All right.
I'll manage that after their birth. And then there's a window of, say, between 1 to 4 that I don't see. And then after that, because I know that palate expansion to widen the palate is quite a central intervention that can make quite a bit of impact, that's when I like to intervene. And I'll do, my favorite age is 5.5 to 6 years. I prefer to do that intervention before the adult teeth come through, where possible.
Of course.
But sometimes if a child is not breathing well or they're having a lot of struggles, I may consider doing that earlier, as young as 4. So that's when I start to see children again, and I'll usually see them till about 8 for orthodontics, but I'll still see people from 8 and above all the way through to adults for oral releases.
It's crazy how I still hear people saying, "No, let's just wait until all your permanent teeth are out." It breaks my heart.
Yeah, I think, it's the way that we were trained, even in dental school, yes, we were somehow taught that you can do early intervention between age 7 to 8 years. However, the attitude is largely try not to burn children out by having multiple phases of treatment. Try to do it at age 12. It's more efficient. You can do it in one phase. You can straighten the teeth, but it really overlooks the poor jaw development that actually contributes to the crowding of the teeth and the malocclusions.
Yeah, I can see where they're coming from, but how amazing is it to just treat it when they're 5 or 6? I completely admire your work. How do you approach it? Do you use myofunctional exercises, or do you combine it with appliances? What's your approach?
Yeah, I think the palate expansion, I use a lot of palate expanders. I use the removable plates, the BioBlock design by Dr. John Mew. I really love it because it actually widens the jaw, but it has special wires that can give me control of the front of the arch as well. And really expansion doesn't make more room for the teeth, the adult teeth to come through. It's really making a V-shaped arch into a more U-shaped arch. That's where we get more spaces. And it gives beautiful facial results as well. So that's why I like to do that. And that's pretty essential. So sometimes, yes, anytime we do early orthodontic treatment, we have to recognize that there's a reason why the jaw has not formed correctly. There is oral dysfunction. Form follows function. So when the jaw structures haven't grown well, it's because there has been oral dysfunction, where the muscles haven't worked well and haven't provided the proper stimulus for everything to grow well. So a lot of the attention has been placed on the tongue, because we need the tongue to lift well, to provide the stimulus for the palate to grow well. If the palate doesn't grow well, it will have a knock-on effect on the lower jaw. But my big thing at the moment that I want to promote more awareness of is that in addition to the tongue providing the proper expansile forces to develop that jaw and face properly, we also need to pay very close attention to the inward pressures that can actually distort the facial development. Because we know, for instance, with pacifiers, which lower the tongue, we have increased sucking pressures from the lips and cheeks, even with thumb sucking, and they are associated with orthodontic problems. But what we have overlooked is the contribution of upper lip tie, cheek ties, and the lower lip tie. So this is something I've been paying a lot of attention to, especially in the last 6 months.
Wow.
So much so that, you know that I'm doing the tongue tie conference coming up in a couple of weeks, and I have the opportunity to speak for 3 hours. So I've collected a lot of cases, and I really want to illustrate how important it is to pay attention to these other attachments. Because when they're restricted, not only do they create oral dysfunction, so I do believe that when these are restrictive, we cannot optimize the latch. Even if we actually address tongue tie to get the tongue lifting correctly, if the rest of the mouth is really tight, we're not going to be able to optimize our latch. We're not going to get the deepest possible latch on the breast. And so in the past, I've released a lot of tongue tie only, but I go back and I look at all the photos and look at all the, you know, when I see the children as they grow older, and I kind of look, what am I missing? And it's all these other oral ties, because even when we do the tongue tie release and they have feeding improvements and they have body release improvements, that they may not be getting the optimal latch or the optimal mouth opening. And they're still communicating or not using their tongue as optimally as possible. And so I study this in my orthodontic patients, these other ties, and what is the facial tension doing? Not only is it affecting the latch, but it's just affecting the way that the facial structures grow. And I've been studying the videos so closely and looking at what actually happens when we release this in all age groups, infants, children, adults, and really tying this information all together to be able to provide a compelling case as to why we need to pay closer attention to these.
Wow, this is impressive. I was not aware of all these other ties. I know the lips, but the cheeks have a tie. Where can you? I'm blown away.
Yes, they can. And if they're tight, a baby will never really be able to get that. Even if we release the upper lip, for instance, they'll never be able to open their lips fully and get that full gape. And now that I've seen some of the latches that are possible when we release cheek ties, I'm really blown away myself. What is possible? And having done quite a few of them of all age groups, I am getting so much feedback. Even as soon as I hand the baby back to parents, wow, that immediate release of facial tension that they can see. Yeah, so it's just as exciting as seeing the feeding changes, because I'm taking so many videos, so many photos that we're able to document this. And I believe, you know, form follows function. If we can address this early, we're going to help structures grow better.
Of course.
Yeah. So,
I'm blown away.
yeah, one of the really center cases that I'm going to be presenting for the first time is an adult who initially consulted with me for tongue tie release about 5 years ago. And because I had seen her baby, and her mouth is so small, like she doesn't even have any room for her tongue, and her quality of life was so poor that I said, we cannot release this tongue tie because you have no space for your tongue to go, and that's going to aggravate all your other problems that you're suffering with. So it's important that you have some sort of jaw surgery to actually open up your jaws. So I encouraged her to do the palate expansion and then the double jaw surgery to advance her jaws.
Oh, wow.
And, yeah. So then she came back to me, and it's a massive structural change because it's changed her whole face. It's opened everything up, and she's ready to do the tongue tie release. And I look around and wow, I cannot believe, because now I'm seeing these ties. She has all these other ties in her mouth that I never paid attention to. And so all this facial tension that actually contributed to her poor jaw development, we actually did, I think, was it 5 releases recently.
Wow.
And it was life-changing. It is actually the most memorable release that I did because there were so many things that shifted, and I'll be presenting everything because everything that could have gone wrong for her during the jaw surgery process did for her. As much as it changed things, she was quite miserable still because she still had a lot of chronic pain and she still couldn't breathe optimally. And yeah, I could speak about her for hours. In fact, I've got about an hour's worth of testimony from her.
Wow.
But the bottom line is that once we did the releases, it was actually, despite palate expansion, the jaw surgery, double jaw surgery, the genoplasty to reconstruct her chin forward, this was the thing that actually improved her breathing the most.
Wow.
She was one of my 4 cases of adults where I've done 2 cheek tie releases, and it's opened up their nasal breathing. That all of a sudden she was feeling air hit in places that she'd never felt before, and those have maintained. But the tongue tie release also helped her breathing because the tongue restriction was associated with this fascial restriction. So her whole body was very tight and stiff, and she couldn't physically deep breathe through her diaphragm because it was creating so much pain for her body.
Wow.
And so she explained to me that even though all these interventions have increased her capacity to breathe, she had a limitation because of the fascial restriction. So having this release in conjunction with osteopathy to unwind those areas and provided an immediate improvement in her breathing capacity. And because of that, it can actually change her sleep that none of the other interventions were able to achieve. And it just released chronic facial pain, body pain, and she just wanted to be teleported 45 years ago. And so there are so many lessons in that particular case. There's so
Would
many
you? It's crazy. Well, I'm in awe with this case, with what you're explaining, because I've never heard it. But would you say that the release would precede a double jaw surgery, or that double jaw surgery was also necessary to improve airway? Because if what you're saying is actual facts, there's a lot of people that would hate to go through double jaw surgery. And if they can do something not simple, it's not simple, I bet, to do a cheek release, but if it's a little bit less invasive than a double jaw surgery, well, I'm in awe. I want to keep listening.
She had to have that surgery, I believe, because her mouth was so extremely narrow and so receded. And I think it was because not just the tongue wasn't working properly, but because of all this other facial tension that had been overlooked. And her face is so much more relaxed now. She can move it more easily.
Wow.
But yes, I do believe that in some cases, by doing these type of releases, we may be able to avoid more complex procedures, or even just buy some time for people to shift their quality of life. Because there have been some cases where I've done it and I didn't really, I've had these breathing improvements that I didn't really expect, in particular with the cheek ties. So I think there's still a lot to discover. There's still a lot to learn, you know.
Yeah, but you're a pioneer on this. I've not heard it before. You're a pioneer on cheek ties.
Yeah.
I've never heard
It's
of
hard
cheek tie.
enough to get people to pay attention to tongue tie. So when we do this, there's obviously a lot of skepticism from mainly colleagues, I would say, mainly other colleagues. And there's always people that are going to say, you are, you know, what do you call it, mutilating babies.
Oh yeah, yeah.
But we need to
That
listen to the parents. We need to listen to them and what is their feedback? What are they telling us? You know, we need to listen to,
no, I completely agree. And regardless of their age, regardless of her age, your patient, she had improvements in her general health from being able to breathe and sleep. I'm trying to get to, we focus on children are more malleable, and adults tend to think, oh, it's age. I'm too old to get this fixed. I'm like this and that's it. Do you know where I'm coming from? So regardless of her age, she managed to improve her health by doing all of that.
yeah, and it's, you know, when you don't get good sleep, it affects your mood, your energy levels. It's hard to function. You're a parent, you've got to try and look after your child. But then to get this new sense of energy, it doesn't change everything or get everything perfect, but to inspire some sort of hope. I think a lot of parents or adults will tell me, it's just given me hope, that it's not so despairing, that they can feel on top of things and be able to manage things better.
Wow.
You know, to go to work and feel like you're not scrolling on your phone trying to avoid things that require concentration, because now you can actually think more clearly. They're the things that, little shifts that actually just make life more easy to live with for all ages. But why don't we intervene earlier?
I know. Yes. Wow. And when you give them, I can imagine that when you're doing all these release, you cut it, a tongue learns a pattern of where it has to be. It's low, let's say, and you cut the tie. You have to retrain the tongue to be in a position that is correct, right? So it's not like you just let them go.
Yeah, it's really important. Doing releases is very similar to taking a cast off an arm. Just because we take that cast off doesn't mean everything's going to move well. We have to do some prehab and to relearn new patterns, because if we don't do that, it's going to reattach or join back together again. And then we've done it for no particular reason. So when I see an infant, that infant, before I do the oral releases, has already seen a lactation consultant, and they've already been doing oral exercises. They've already been doing some body work to get the body looser, so that everything can work properly as soon as we can. And it's not always immediate, because when we've got this mobility, we have to get some strength, and even doing the other releases to make the rest of the face more relaxed, to change from a more shallow latch that uses all our lips and cheeks to then get a deep latch and to now use our tongue differently. Yes, there's a lot of work and oral therapy that begins before we even do the release. But then as we go to children and adults who have more compensations and they're so used to this altered function, it becomes even more important to retrain awareness of what normal function looks like, and to build that coordination and the tone before we go ahead. And therefore people can get the muscles moving differently post-release to minimize that reattachment.
Of course. And what would some exercises be? Do parents start doing it on practicing with their child at home, or do they only do the exercises when you're present?
Yeah, I think really you have to work with someone that does that sort of myofunctional therapy or the oral exercises. So with a lactation consultant, they usually give out the bunch of exercises, and it could vary depending on what they see as the issue. And then they have like an app where parents can mark it off, when they've done it. So that's how it would work with a baby. And then with an adult or a child, yes, working with a myofunctional therapist. It's not something that I would personally be involved.
Of course. All right.
Yes.
I do. Here in the UK, I've not found my functional therapist where I work. But because I've read so much, I try to give them like little bits of advice with how to train their tongue. And the one that I use the most is the rolling your tongue from the back to from the front to the back, and then from side to side with rice, with a grain of rice. And then doing like isometric and isotonic exercises. That's what I've learned. And I feel like that's giving them that bit of hope that you were talking about. A kid just has a taste of what good breathing is. But I don't know if I'm right. Maybe you can help me plan my exercises better, or actually refer to a myofunctional therapist.
It's always difficult because there's always differences in accessibility to care in different places. There's a myofunctional therapist in the UK. I think their practice is even named Myofunctional Therapy UK. Her name is Yuli. Are you
Yes, I've heard of her. But it's I'm in the north of England, and she's in London, I think. I certainly know. And she practices in Spain as well. I am aware, yes.
Yeah, I think in Europe, I get reached out to by so many people like yourself that are developing an interest. So I think it's only a matter of time before this becomes more easy to get that access. And I see a lot of integrative groups where there's a lady, Helen Jones. She's a retired dentist. Have you heard of her?
Helen Jones. I think
she's very active in
English.
Yes, in UK, she's very active in bringing together different specialties to, discuss integration, and so there's a lot of change. Yes, but yes, in an ideal world, it's great to have professionals that are highly specialized, but we all have to do the best that we can, and every bit of information that we can give to our patients is helping them. Yeah.
Completely. I wanted to wrap up the conversation talking about where the tongue tie comes from. I feel like sometimes people say, "Oh, it's fate. I'm like this. It's genetic, and I've been born like this, and that's it. I'm crushed, and this is my life now." But I would love to know if there are any risk factors during pregnancy or anything in the birth. You tell me.
I'm going to say that I actually am no expert in this area.
All right.
Yeah.
Okay, so no conversation. I do think I don't. Talking to other colleagues of mine, they've said there may be a genetic factor, but for me, putting everything down to genetic is a bit unfair. But okay, alteration in the genes. We'll just say that.
Yeah, it definitely runs in families. So I've heard that if you have two genes and one of them is for tongue tie, then you will most likely get the tongue tie because it's a dominant trait. But yeah, it's hard to know if it's epigenetic to do with modern environment. What I do feel is that it has been missed. I see a lot of adults. And if we can recognize what normal function looks like and what dysfunction looks like, it's more common than we think. So it's there. I just think that we haven't paid close enough attention to what is normal and what is not.
Our first approach would be to assess whether we can restore correct breathing and airway without doing the tie release, or would we automatically go into releasing the tie? Because a lot of parents are a bit scared and reluctant to cutting they think it's very invasive, which fair enough. For a baby, you may think it's very, very invasive. But I was wondering if you could use like a Mayo Munchie or a Mayo Brace to see if you can retrain that tongue before you have to cut the tie. What's your opinion on that?
Yeah, definitely. We want to have, the ultimate goal is really tongue suction, the tongue suction lightly to the roof of the mouth for better breathing, better palate development. But just by jumping in and doing a tongue tie release, that's not really going to solve the problem or promote that. So I almost feel it has to be often the last piece, particularly being a more invasive approach. We need to make sure that there's tongue space, that there's tongue tone. We address any other problems that could actually prevent that tongue to palate seal. If there's nasal obstruction or enlarged adenoids or tonsils, we need to really make sure that we've addressed all the other factors and not sort of implying to parents or patients that this is going to be the fix. So yes, generally speaking, I want to make it the thing at the end that actually promotes that tongue up, rather than if we do this, it's going to change your breathing and sleep.
Fair enough. And what is the biggest change you've seen in a child at more of a neurological area? What is the biggest change you've seen after doing your therapy? I'm going to say your therapy because I feel like you're an all-rounder. You do restore breathing.
What is the biggest change? Wow, every day there's big changes to get children sleeping better and breathing better, but and to be able to not have to struggle through their school. But really, I think that the most satisfying thing about treating children is the impact on the entire family. Because when a child breathes and sleeps better, it can reduce the stress on the parents. And it can actually alter the whole family dynamics where, one child might be getting all the attention compared to others. So it can improve the whole family dynamic. And when a parent doesn't have to worry about that child, for instance, if they're not having to take off time because their child's always sick and they have to give up what they really want to do, it allows parents to be their best selves as well. Because I've seen where if a parent is struggling with their child and people keep telling them that there's a problem with their child, it stresses out the parent. And then that parent can't be, their freest self. Or,
Of course.
So I think really treating children, the best thing is not just treating the child and helping that child actually live life easier. It's actually just changing the parent and the family and how they can show up in the world as well. So I think, that is what I love doing for children.
Crazy how much of an impact we have.
Yes.
Well, we can have on a household.
Yeah.
Wow.
Yeah.
All right. Well, I am impressed with the whole conversation. I don't want to keep your time if you've got somewhere to go. I heard you're working. Is there anything that you would like to add? Maybe some tips for parents that are they're having their first child. I know first child is always like a surprise. What can we help them?
Yeah, it's really recognizing that the importance of healthy mouth function and helping parents to be informed. What are the mechanical benefits of breastfeeding? And just empowering them with information so that they can make their choices and know how this is going to play out in the long run, so that whatever they decide, they've been fully informed. And recognizing that, so breastfeeding, the contribution of that and the impact of pacifiers, and really promoting nasal breathing from early as possible. And I really want parents to know that to achieve nasal breathing, it's a multifactorial issue. it's not just about going to the ear, nose and throat specialists. We actually need to look at the outer borders of the nasal passages, the palate being formed, that forms the floor of the nose. So really helping parents understand that as well. You need to look at the dentist or the orthodontist as a critical piece of the puzzle when trying to establish this. But then also getting that tongue position correct and the lip seal correct, and there's so many professionals that need to be involved with it. So really my book Brief Sleep Thrive is really about helping parents to understand what are the earliest clues of issues and what are the various pathways that parents can pursue. And if we miss one thing, don't be stressed, because there's always different things that we can do to intervene as children get older. However, the earlier we can have this information, the better.
Of course.
Yeah.
Of course. Well, thank you so much, Shereen. Dr. Lim. Wow. I'm impressed with all your work.
Thank you. I really appreciate your interest.
Tomar las riendas.